Hello and welcome. My name is Sean Holt. I am a licensed paramedic with RCL Services. Today we're going to be doing a little bit of an introduction to cardiac, everything cardiac. And we're going to start with the anatomy and physiology of the heart, including blood flow through the heart, including the valves and everything like that. So let's talk some basics. This is the exterior of the heart. It appears to be healthy, pumping appropriately, and if we look over here, we see our rhythm strip that goes with the rate and the rhythm that this is pumping in a normal conductive fashion, which is like this. Basic electrophysiology says that whenever we're looking at the electrical activity of the heart, it's best if we slow it down and take a look at what's really going on. So up here at the top, you'll see the SA node fire, okay? Right there at the very, very top right. Now, that's the SA node. This one in the middle is the AV node, and it has to stop all of its electrical activity after the atria. It all has to collect at that AV node, or the junction as we call it. So it stops there, and then it continues through the bundle branches and then to the Purkinje fibers. Okay? So this is the normal depolarization effect of the heart. We want the heart to pump in this organized sinus rhythm fashion because it is the most effective way for the heart to beat and pump upward towards all of these valves. You notice that at the bottom of the heart, the apex that is sitting up against the diaphragm, this inferior part of the heart right here pumps upward towards these valves, okay, these two middle ones, okay, so let's rotate that and move in a little bit. So these two valves are your semilunar valves, okay. The semilunar valves include the aortic valve, this one in the back, and then the pulmonic valve. This one is the one that's going to head to the lungs from the right side of the heart. The aortic valve is going to come, it's going to bring its blood from the left ventricle over here up through the atria, up to the carotid arteries, to the upper extremities, and then down the descending aorta to go down to the lower part of the body and distribute blood appropriately that way. But the big thing to take away from this part is that the heart contracts in a way that's from this apex of the heart down here upwards towards these valves, okay, because that's the most effective way to get the most pressure into those valves, out into the pulmonic system from the right and the systemic circulation from the left side of the heart, okay? Systemic meaning body, okay? So the aorta will pump blood out to the body, okay? After the body, again, we recollect. We can look at the exterior of the heart to do this. It will recollect after it's gone through all the distal tissues to the single-celled walled vessels, to those micro vessels and capillaries, and when they've had its exchange and it's now deoxygenated and waste-filled, it will recollect from the lower body, the inferior vena cava, and from the superior part of the body, the upper body, it'll come from the superior vena cava, and it all recollects in this right atrium, okay? So let's look at the heart as a pump. We still have it really, really slowed down for this cardiac cycle, so let's speed it up about half the speed that the heart actually pumps in a normal rhythm, okay? So we see that blood will come to the right side of the heart via these vessels, okay? That's the superior inferior vena cava. Right atrium pumps to this valve right here, which is known as the tricuspid valve. That is because it has three cusps on it. Okay, if we look in closer, we can see three cusps. Okay, whereas the bicuspid, the other atrioventricular valve, only has two, and that's why they call it the bicuspid or the mitral valve. Okay, but over here we just have the tricuspid coming from the right atria to the right ventricle. Okay. Once we are there in the right ventricle, we're going to pump out to these pulmonary arteries. All right, pulmonary arteries because they're moving away from the heart, but they are opposite in that they're from the normal vessels in the body, as this is carrying deoxygenated blood inside of an artery. All right, that's not usually the case, but it's backwards for the heart because of this two-sided pump and it needing to go to the lungs to be reoxygenated and get rid of those wastes. Okay, so think of a two-sided pump, and this is, again, what the interior will look like. Okay, so after it goes to the lungs via the pulmonary arteries, it's going to return via the pulmonary veins, but this time it's going to have fresh oxygenated blood. Okay, fresh oxygenated blood coming to the left atrium. We're looking at the left atrium right here, okay, at the end of this line. That's the left atrium, and a lot of blood collects there to be pumped down to the largest and strongest chamber of the heart, which is the left ventricle. Okay? When the left ventricle contracts, it pumps out of the aortic valve, this one right here, and it follows the aorta up the carotids and the subclavians and down the descending aorta to the inferior part of the body. Okay. So that left ventricle has a strong wall, very, very thick muscular wall to it, because it has to contract blood all the way through the resistance of the systemic circulation. That means it requires a large amount of blood forcefully struck, and the cardiac output must be sufficient to fight the resistance of the body to move that blood forward. But as it's a forward continuous pump like this, and it's continuously pumping all the time, the body gets used to that forward blood flow, and that's just the expected way for it to circulate. All right. So let's look at the valves one more time, and let's talk about the valves. These two closest together in the center of the heart, more so as it looks like, those are called the semilunar valves. Okay, semilunar valves, the aortic and the pulmonic. They call them the semilunar valves versus the atrioventricular valves, because those are anatomic names. All right, for these other valves. All right, so here we have the bicuspid versus the tricuspid. Tricuspid's on the right side of the heart. The bicuspid is on the left side of the heart, between the atria and the ventricles, respectively, on both sides. We've already looked at conduction. We'll speed up that cardiac cycle to full speed. And let's turn the rate down just a little bit. We'll slow it down to about 50. This is what a healthy heart should be looking like. More so, maybe with a little bit faster of a rate. But this helps to give us a good idea of what electrical activity should look like in the heart. Okay? Let's move on past conduction and into the circulation. All right? Circulation of the heart is extremely important. We're going to start with this view, and then we're going to go into another view of a heart vessel, also known as these coronary arteries. But I want to show you a couple of things with these coronary arteries first. Obviously, we have this very large aorta up at the top, but we have two large vessels coming out of the base of the aorta over here next to the aortic valve, straight ahead. All right, so let's rotate. We'll take a look in there. That aortic valve, those three leaflets, actually serve as covers and doorways to the ostia, or openings, of these coronary vessels. These coronary vessels perfuse the heart muscle. There's one coming out of the side right here that I'm pointing at called the right coronary artery, because it goes down to the right ventricle. All right, and it also perfuses the inferior wall of the heart for a lot of individuals. Okay, the other one that we see coming out of the base of the aorta right here is the left main coronary artery. Okay, the left main. Let's take a little bit different view. The left main you can see from the back end right here. Okay, the left main is actually really short because there's a bifurcation. All right, a pretty important one. All right, so if you look right here, I'm gonna show from a little bit higher up. But because of that bifurcation where it splits and it goes down the front of the heart with the left anterior descending artery, the LAD, it actually goes around the back of the heart with the circumflex. That's that red vessel that goes around to the back and then down the posterior wall of the heart. Okay, so let's go look. We're looking at the front of the heart again. We see the aorta. We see the aortic valve. We understand that those are the openings to the coronary arteries behind those leaflets. Whenever the pressure becomes higher in the aorta, okay, is when those vessels will get perfused. We call that ventricular diastole. So that's when the ventricles are relaxing and repolarizing. Okay, we won't get too much into those terms, but this is going to show you a little bit of why it's important to understand. The left main is very short. Okay, and this is it. This is the extent of it right here. But then once it cuts down the left anterior descending, the circumflex around to the back and down, if we get a clot right here in this vessel, this left main, it will kill 2/3 of the heart almost instantaneously. That is why a large clot coming from the left ventricle, all right, being pumped out to the aorta, is such a risk to either go to the heart for a heart attack, all right, by the entrance of the aorta, or that same clot traveling up further and maybe going up to the carotid artery, all right. That would cause a stroke, right? So there is the ability with something called atrial fibrillation where these clots become more common to be made or formed in these atria back here. Okay, we'll look at the exterior of the heart again. These atria sometimes will fibrillate in atrial fibrillation, and those clots can be formed and travel down these coronary arteries or cause a stroke. So a heart attack or a stroke in either one of those cases. All right. However, a PE, a pulmonary embolism, is going to be something that has been pumped through the right side of the heart and pumped through the pulmonary arteries into the pulmonary circuit. That's where pulmonary emboli do their damage. And if we block one of these pulmonary arteries completely going over to one side, that is half of our blood supply not getting oxygenated. All right, so becomes a very, very big problem. These patients can die very quickly, need intervention as well. We'll talk more about those whenever we get to respiratory emergencies. But that's a big part of understanding everything cardiac. Okay, this is all a really, really great view, but I'm going to change one thing. We're going to go back real quick and look at coronary artery disease. I'm going to sit back down. We're going to take a look at this right here. Okay, we are looking at the epicardium. This is the exterior of the heart. Okay, the muscle on the outside of the heart, and this is a coronary artery. Okay, what we're looking at right now is a clean coronary artery. All right, a vessel that's going to be perfusing the heart, right? Now, somebody that has coronary artery disease, sometimes risk factors include being on birth control, smoking, being overweight, having high cholesterol, right? All these things will start to build up to lead to coronary artery disease. And this is what that can start to look like, okay? These cholesterol and calcium buildups with fatty deposits in them can actually rupture and leave this area and travel on to cause a larger clot further downstream. All right, so this in a coronary artery is not a good thing. Let's make it a little bit more severe, okay? A little bit more severe, we see, maybe 50% occlusion right here. Only 50% of the blood is making it through. Maybe that's not enough blood and oxygen to get to all the heart muscles. So maybe this person gets chest pain after exertion sometimes, okay? Worsening case. Here is almost near full occlusion of this vessel. If this was a full occlusion, everything from this point distal, all of this heart tissue that would normally be perfused by this vessel is not going to be perfused. It is going to die. It will not be effective for contraction of the heart, and therefore we will not have a blood pressure worth anything once that dying tissue spreads. So what do we want to do with heart attacks? We want to give antiplatelets. We want to get them to a cath lab. Okay, antiplatelets going to be in the form of aspirin. Aspirin we give 324 milligrams, chewed up baby aspirin, 4 of them, which are 81 milligrams each, and those have antiplatelet properties. Basically, if one of these clots were to, or one of these buildups of cholesterol right here were to peel out because of turbulent blood flow, rip open, and pass further down the line and cause a clot right up here ahead, giving an antiplatelet such as aspirin is going to keep that clot from getting bigger. It's going to keep platelets from getting sticky, aggregating, and then making that clot larger. Okay, so we keep our heart attacks from getting worse and causing more damage by giving that aspirin early. Okay, but this is what they're going to do at the hospital. We get this patient there, we've given our aspirin, we've given our nitroglycerin to hopefully reduce the workload of the heart and reduce some of the chest pain. But the hospital is going to have PCI, percutaneous coronary intervention. And this is what that looks like. It is in the form of a balloon with a stent that is placed to open up this blockage. The balloon is removed, the stent remains in place, even with the fatty deposits that are expanded outwards, and there is guaranteed blood flow, at least in this spot, in those coronary vessels.